Thank you so much for having me. So I'm going to talk about some opportunities to become a champion, and this is what I'm going to cover. Since I think this is probably a pretty diverse audience, I'm going to do some things, say a few things that might be a bit rudimentary, but bring everybody on the same page. I'm going to talk about some successful dementia care management strategies, and then I'm going to focus on being a champion. So I like this slide a lot. It's something that I developed a few years ago, so some of the data are just a wee bit old, but it starts in 2030, not that far away, and that's about hopefully when I'll, not before then, when I'll be developing my Alzheimer's disease. And I hope by that point, and this is where a lot of the focus and a lot of the research is being done, is that there will be risk factor monitoring. There'll be a blood test that will tell me with some certainty that indeed I am at high risk for developing dementia. That blood test could be monitored and to see when the early signs before I start losing my cognition. There will be preventive measures so that once these risk factors are detected, I will be able to take a pill or an injection and not get the disease. Detection, obviously, and treatment. We'll have better treatments. And then there will still be the need for support. So that's 2030. We have 12 years to get there, and a lot of money is being put into that. But now, in 2018, we don't have most of that. What we have is we have pretty good ways of detecting whether you have Alzheimer's disease or other dementias. We can tell whether you have it or not. And we have mediocre at best medicines for treating it. These are not home run drugs. If anything, they're kind of a scratch single drugs. And then we have support. We have support, and we're going to talk a little bit about that. And that support can be either in the healthcare system or in the community. And in fact, it's both. It has to be both. So the burden in 2018, and these were just data that were just downloaded very recently. 5.7 million have Alzheimer's disease, and that represents about 60 to 80% of the burden of dementia, so you have to multiply that a bit. And the costs are 277 billion, and 186 billion of that is borne by Medicare and Medicaid. And then the family caregiver statistic, 18.4 billion hours of care, valued at 232 billion. And I would venture to say that probably everybody in this room has been touched by Alzheimer's or other dementias. You have a family member, a friend. It's just that common. So you know what I'm talking about here. So these are some data that we collected from our study, that these caregivers are having trouble. 14% have depressive symptoms, enough that would merit treatment either by psychotherapy or medications to that level. 36% report high stress. That's huge. They also have very low self-efficacy. Only 1 in 5 knew how to get or where to get resources for dementia care. 36%, about 1 in 3, felt comfortable handling dementia problems, and only a quarter of them felt that they had a dementia care professional who could help them through their problems. Interestingly enough, and not on the slide, about 3/4 of them said that their doctors understood dementia and their doctors were sympathetic, but they didn't have anybody who could help them. So this is the other shoe that doesn't look so good. And this is, in the third set of smokestacks there, this is the quality of care for dementia. And these are studies from 1998 through 2008. So there's 4 different cohorts of people studied. And what you see there is that the quality of care for dementia has not improved. And it's hung around 40%. So they're not, people who are who have dementia are not getting the proper care. And I'll show you in a few moments about the kinds of things that they're not getting. So how do we manage dementia? And this is not supposed to be a lecture on dementia care, but basically there are 2 kinds of drugs that we use for trying to do something about the disease. slowing the progression. One are cholinesterase inhibitors, and these have the trade names of Exelon and Aricept and a few others. And then there's memantine, which has a trade name of Namenda. And these are drugs that are used very commonly in the treatment of the disease. But much more important, because the drugs aren't all that good, is managing the patient. And the first thing you have to say is, and in disclosing this diagnosis, is that this is a lifelong disease. There are no cures for dementia at this point. And you have to play the ball where it lies. You play the ball, and if it's early, you get the patient involved as much as possible. If it's later, it's primarily the families and the caregivers who have to speak on their behalf. And you want to aim for the highest level of independence that works for everyone. And that works for everyone is an important clause, because if the patient is staying at home, but the caregiver, his life is being ruined, you really just haven't done much. So it's got to work for everyone. You need to manage hot-button items such as driving and living at home and living alone, cooking, those kinds of things, and then managing the symptoms. So the best way to manage the symptoms, both in terms of efficacy and also in terms of side effects, is through behavioral therapies. One of the things that we have been able to do through a couple of grants is create some really nice videos, vignettes of how to manage specific behaviors, wandering, refusal to take medicines, repeated questioning, repeating calling people on the phone. And those are available free. They have something like 250,000 hits on them on YouTube. And then there's drug management of complications. And the drug management of complications, once again, is not a particularly satisfying treatment. These drugs have side effects. They have black box warnings. We try to use these as a last resort. Advanced care planning is a tremendously important construct that is part of dementia care. And early on, many patients will be able to tell you kind of what their goals and preferences are. But if they aren't, then the caregivers really need to begin to think about this as early as the time of diagnosis. Manage the comorbidities. We just did some interesting work at our own institution where we're looking at the high utilizers who have dementia and what the diagnosis they were admitted for. So you say, geez, these are patients with dementia, they have a lot of behavioral symptoms, they're all winding up in a psychiatric hospital for behavioral symptoms. No. What do they come in for? They're coming in for mostly for infectious diseases. Pneumonias, urinary tract infections, skin infections, things like that. So if we're going to decrease utilization, maybe we want to be aiming towards reducing those infectious diseases. So those comorbidities, and then caregiver support. And I could spend hours and hours and hours about caregiver support. They are the most important resource that a person with dementia has. And I tell that all the time. I say to the students, I say to the families, I say, I'm just the doctor. I'm just a doctor, and the most important person in your life is going to be your daughter-in-law, your son, your caregiver. But this exacts an important, a very important toll. About 50% of caregivers become depressed. And the more knowledgeable and empowered a caregiver is, the better the patient's care. And we see this a lot. We see patients whose daughters and daughter-in-laws are calling us all the time, but those patients are the patients who get the best care. So there are a lot of caregiver resources available, local Alzheimer's organizations, including Alzheimer's Greater Los Angeles Alzheimer's, and other community resources. And then there are specific programs that are aimed at caregivers. And some of the names you'll hear are REACH, NYUCI, Savvy Caregiver, Partnering with Your Doctors. These are all discrete programs that are ready to be disseminated and used. So there is evidence behind this. Several of the people in this room and I were at a wonderful conference last October in Washington where the evidence was reviewed. Over 200 interventions have been tested in rigorous trials. These tend to be behavioral management, skills training, and counseling and psychotherapy. And they have shown benefits. These have been small to moderate benefits, not home runs, but sometimes very clinically meaningful in caregiver knowledge, caregiver well-being, caregiver confidence, self-efficacy. Some have actually shown reduced, prolonged time until they're institutionalized, the patients, and reduced behavioral symptoms. However, there is a cost to this. These caregiver support interventions, as Katie Maslow was just telling me this morning, the way she characterizes, they tend not to have coordination of care. They tend to be about supporting the caregiver. And they've been tested in traditional research settings much more so than in pragmatic, true clinical care. And probably the most concern is they're expensive. These are not cheap. They're $250 to $5 a day for 6 months, so you're talking up to $900 per year for these interventions. And right now, there's no reimbursement essentially for them. This is pretty much out of pockets or through grants, et cetera. And they haven't been well integrated with the healthcare system. So they tend to occur in the community, but not so much communication back to the health system. So in response, there have been a number of new models that have been created that are more comprehensive. And these focus on the patient and the caregiver, and coordination is a large component. And they fall into two categories, at least by the way I see it. The first are those that are based in the community. And the classic example of this is something called the BRI care consultation model that was developed at the Benjamin Rose Institute in Cleveland, and it's a very impressive model. Another one that is been developed and tested is called Mind at Home, and that was developed at Johns Hopkins, and primarily focuses on home visit. And then there are a couple of health system-based interventions that I'd like to mention. The first and really breakthrough work was conducted at Indiana University and subject to a randomized clinical trial about 12 years ago. It was published. And that was the Healthy Aging Brain Center. And we'll talk a little bit more about some of the principles there. And then the second is, we're kind of a relative Johnny-come-lately, the UCLA Alzheimer's and Dementia Care Program. So these community-based models, these tend to be implemented at community-based organizations. And the key player there, the key care provider, tend to be social workers, nurses, or MFTs. And what they do are systematic assessment, care planning, delivery or referral of care, services and support. And they may or may not have in-person visits or home visits. So for example, the BRI care consultation model is all telephone. And there's some pros and cons of that. So one of the pros is, it works for rural people as well as it does for urban people. The MIND program is pretty much exclusively home visits. So there are different models here. But they do have efficacy. They reduce caregiver burden, strain, and depression. Better guideline associated care, better quality of life, reduced patient behavioral problems. Some have shown reduced nursing home placement, but they have not shown effects on healthcare costs or utilization. A big component of this is coaching. So it's coaching the caregivers to be able to get that kind of care. And that has some pros and cons. Number one, the con is it's kind of one step away. But the pro is that it helps empower the caregivers. So these are very interesting models. The health system-based are generally implemented by nurse practitioners. And that was the original health ABC model in the dementia care program at UCLA, or physician-led staff. So the Indiana program has progressively moved towards having physicians and a few nurse practitioners or nurses, and then people who are at much lower level trained, even high school graduates who are going into people's homes. So the model has evolved over time. These all have at least face-to-face annual visits. And the coordination is within the health system. so that these the dementia care managers here are employed by the healthcare system. They have access to the electronic record. They communicate just like any other provider in the healthcare system, including writing orders, so that they can discontinue medicines or start medicines. They may or may not have home visits. And what they've shown to have is better quality of care, and I'll show you an example of that in a bit. Reduced caregiver burden, strain, and depression, reduced nursing home placement, and at least some of them have shown lower healthcare costs. Okay, so you want to be a champion. Everybody wants to be a champion. There's nothing better to be a champion for than dementia care. That's why we're all here. And the first thing to do is to frame the problem. So to make something meaningful, and you can use some data. So our health system is very interested in overutilization, utilization that's higher than expected. And they identified 3 conditions where this was happening. The first were chronic kidney disease, and a lot of the chronic kidney disease problem was because the access, the fistulas, et cetera, were getting clogged, and they couldn't get a radiologist to unclog them and such like that. So they were incurring very expensive care. Dementia and oncology. Those are the 3 ones that are really important for UCLA. So why is it important to focus on high utilizers? Because increasingly, and this is where the puck is going, both statewide and nationally, is towards capitated or managed care. And it may not say managed care, but it's managed care. So the whole idea of Medicare Advantage, which is growing in most states, ACOs, these are accountable care organizations, and MSSP, which is Medicare Shared Savings Plan. The idea here is if a healthcare organization can control costs, that the federal government, Medicare, will give some of those cost sharing back to them. So UCLA and many other institutions have an ACO, and so this becomes all of a sudden very important to them. So then you want to identify solutions. You identify the problem, it's getting their attention, and then identifying solutions. So I will mention a little about the UCLA Alzheimer's and Dementia Care Program. It is a program that approaches both the patient and the caregiver as a dyad, because they both need support, and if you treat one or the other, you're not getting the whole picture. It recognizes that this is a long journey, and it provides comprehensive care that is based in the healthcare system but reaches out to the community. It uses a co-management model with nurse practitioner dementia care managers who do not assume the primary care of the patient. So for this program, you have to have a primary care program who's willing to partner with the program. It works with the doctors to care for patients by conducting in-person needs assessments. And here we find out what the person's needs are and what kind of resources, whether they be financial resources or human resources, to deal with this. Develop and implementing individualized dementia care plans, monitoring the response and revising as needed, and providing access 24/7 so that there's never a crisis where they can't get somebody on the phone. And it partners with a community-based organization to provide direct services such as adult daycare and caregiver training. So this is a very interesting model. We got a CMMI Innovation Challenge Award. We were one of the first in the country. And one of the kind of stipulations of that grant was how were you going to work with the communities? And it turned out UCLA had these kind of community-based resources, but never any kind of formal affiliations with them. So a good chunk of our initial grant from Medicare, from CMMI, was to provide funds for community-based organizations to provide services. And what we learned was this was incredibly valuable. We learned a couple things. One, we learned that it was incredibly valuable for our patients. And the second thing we learned is that doing block grants was not the right way to do it. Because that's typically how community-based organizations, they receive block grants and then they do the work. And we set up a kind of a unique voucher system so that basically the dementia care managers would see a patient and say, geez, you would really benefit from adult daycare. And, but no, I wouldn't want to go there. I'll tell you what, we'll give you 5 days of adult daycare for free. We'll just give you a voucher and then see how you like it. If you like it, keep going. Okay. Or you need some respite. So we are going to give you services for respite care. Or you need some individual one-on-one counseling with an MFT. We're going to pay for 3 sessions. So this is kind of an odd kind of way of thinking. This is the healthcare system dollars essentially, going out to community-based organizations. So basically what we do is we make the referral, and we do this through an electronic software system. The patient redeems that, the community-based organization invoices, and we pay them. Provide data. So this may be a really good idea, and you may be very excited about it. You may have a lot of testimonials, but that is not going to carry the day at the C-suite. So you want to provide data on quality, cost, and return on investment. We've done a few studies where we've compared the quality of care, and these are using standard measures, ACOV3 and Physician Consortium for Practice Improvement, quality indicators. And we find that if you leave this to docs alone, they are well-meaning but do not get the job done. Only about 40% of recommended care is delivered. If you add a nurse practitioner who does kind of everything, but not specifically focused on dementia care, you can get a bit of a boost there. But based on chart reviews of the first about 800 people in the dementia care program, 92% of quality indicators were met. And among the 4 dementia care managers, there was no difference. So the idea is giving a product that is consistent and consistently high quality. And the administrators like that. And so these are some examples. These are kinds of things that should be done if somebody has dementia care. Obviously, annual assessment of cognition, staging the dementia, things like measuring function, depressing screening, screening for behavioral symptoms, reviewing the medicines, caregiver counseling, counseling about advanced directives, counseling about driving. This is just a few of them. But you see these are very, very high percentages because this is the dementia care manager's job. This is their job, is to provide high quality care for dementia. So they also like to see figures like this. This is not a slide that I generated. This was actually generated by our faculty practice group that shows that there's $500 per month spend reduction by people who participated in the program and didn't, who have dementia. So roughly $2,200 per month if they're not in the dementia care program and they have dementia, versus $1,700 a month if they are in the dementia care program. They like that. And they particularly like slides like this. This is another one of their slides, not mine, is that it reduced inpatient spends. And why do they want to reduce inpatient spend? Is because if they reduce inpatient spend, they beat the DRGs, which is how they're paid. But the other thing it does is it gets people out of the hospital so new people can come in the hospital. If the hospital's full, which our hospital typically is, if they're clogged up with any kind of patients, including dementia patients, that they can't get new patients in. So they like that. And this just puts some numbers to this, and not all these numbers are different. And I will certainly be honest with anyone, is that the dementia care program does not prevent admissions, hospitalizations. We just haven't been able to show that. We've looked at it 3 different ways and haven't been showed it. And really, there's no significant effect on 30-day readmissions. But what we have been able to show is that if somebody is in the hospital, their length of stay is shorter. And why is their length of stay shorter? For several reasons. One, the dementia care manager's notes are really good and help the discharge planners. Number 2 is the dementia care managers reach out to the hospital team and say, is there anything we can do to facilitate this discharge? And number 3 is that when their patients are discharged, the dementia care manager will pick up. So it reduces the length of stay, and a 0.7 length of stay on average is big. The other thing it does is it reduces ICU stays. And the reason it reduces ICU stays is because the dementia care managers have already had discussions about end-of-life care and about advance directives. So a lot of these people do not want to go into intensive care units. So what does it cost to staff a program like this? The program at its peak had 5 dementia care managers who are all nurse practitioners, 2 assistants who help them with patients who are not quite as critically ill. Let me just say this, 5 dementia care managers each have a panel of 250 patients. That's a huge panel if you're doing care management, huge. A half-time medical director, a program administrator. We have some psychologists who are doing support groups. We have 5 different support groups. Software, we had to build software for this program, and that maintenance. And then into our budget, we have vouchers for community-based services. The overall cost of the program is a little less than $4 a day. When you compare that with it's about the cost of generic rivastigmine and much less expensive than the transdermal stuff. And we figure that if we bill fee-for-service Medicare as aggressively as possible, we can generate about $900 per year per patient. Okay. So there's still a shortfall. ROI. So this is what, when we present this to the health system, they do their own separate analysis because they don't believe anything we would say. They want to know about net revenue savings, total incremental operating costs. In other words, what more do they have to put in beyond the savings, the contribution margins, payback periods, how long do they recoup their costs, and investment return ratios. So this is all stuff that I try to ignore as much as possible, but it's important to them. And for UCLA, the program doesn't completely cover its costs, but it saves a lot of money for the healthcare system. So it's not a money gainer. But that really is dependent upon labor costs. And the labor costs of the key driver of our program is the dementia care manager, who's a nurse practitioner. And I would say that the UCLA, maybe in most of California, the unionized nurses have incredibly good salaries. And if you were doing this program someplace that was rural or someplace in another state, you may actually be able to save money doing this program. So I want to finish up with thinking broadly. And thinking broadly is kind of maybe the next steps of thinking about the future. And here, this is a population-based approach. So let's say that you are a healthcare system, or you are a Medicare Advantage program, or you have a set of people that you are responsible. And here, you can use analytics to characterize that population, tailor interventions to different strata, providing appropriate resources efficiently, and managing transitions. So just to go through this, what we did at UCLA, we identified approximately 4,500 people at UCLA who have dementia, about 4,500. So the top 1% is 45 patients. And these people tend to have severe behavioral problems, functional impairments, few resources, and lots of comorbidities, The next tier are people who often have behavioral problems, few resources, comorbidities, multiple ER visits, but not as much. The third tier may have behavioral issues, but they're not huge utilizers. And then there's these 2 bottom tiers, and these people have dementia, but they're not having behavioral symptoms, and they don't use very much health care. Now, what do we mean by using health care? So this top 45 people, on average, incur $193,000 per year of health care costs. That's a lot of money. If you make a 10% difference in that, you can do a lot. The next tier is $71,000, $22,000, and these 2 bottom tiers is less than the Medicare average. So what you need to do is to plan for each of these populations that you give them the right amount of care. You don't want to give them too much or too little. So for the top tier, we actually have what they call an extensivist program, who has staffed by an internist who has extra resources, extra case management resources, all sorts of things to manage these people. And they get a lot of palliative care, advanced care planning. The second and third tier is really the sweet spot for the dementia care program. And the fourth and the fifth, where we're developing something called Alzheimer's Dementia Care Program Lite. And this would be much more about kind of just-in-time resources and monitoring these people to see when they transition. So finally, and since I have less than 1 minute left, provide data, persevere. This is a very, very tough road, even at a sympathetic institution. You are going to have so many doors that are closed to you. And every time you start to get through a door, the next door will be bolted. So you just have to keep nailing away, hammering and hammering away at it. And finally, bring passion to it. That passion will get you through those doors, develop contacts, have people on your side, and fight the good fight. It's not going to be easy for anyone, but if you bring that passion, you have a great chance. So I'm right on time, and I'm going to stop, and thank you so much for enjoying.